Today we're going to do the care and treatment of individuals with PIDD as well as HIV and AIDS. Here are the 3 objectives that we are going to focus on during this lecture. You can pause and read those on your own. So PIDD, it stands for Primary Immune Deficiency Disorders. And the main reason we're bringing this one up here is we live in Missouri. There are a lot of people who have a lot of allergy-related things going on. And sometimes it may or may not be related to allergies. It could be something with their immune system, could be both. However, our goal as nurses is to recognize when someone has allergies, not just blowing it off, all right? So these PIDDs, it could be a group of more than about 300 disorders, all right? You do not need to know each and every one of these disorders. Again, I just kind of want you to know what PIDD stands for and means. A lot of times these are they have some sort of defect in their immune system, or it's missing a key component, okay? So these patients are constantly getting infections, and when we give them antibiotics, it's just masking the symptoms, all right? So one thing you'll notice is that many of these disorders have the name autoimmune or immunity in their name. Know that most of these are genetic, however, not all are, and the majority are diagnosed in infancy. Occasionally, adults actually could present again with these resistant, recurrent, persistent infections, such as like a sinus infection, bronchitis, pneumonia. So if this is constantly happening and we can't figure out why they're constantly getting this stuff, it may or may not be something with their immune system. This causes the frequent use of those antibiotics. Again, it kind of masks the symptoms though, right? So many of these patients also, they have comorbid autoimmune disorders, such as things with their thyroid. So they could have a hypo or hyperthyroidism, rheumatoid arthritis, or inflammatory bowel disease. So as a reminder, a little visual representation here, these are the clinical manifestations again. They could have persistent infections, so like those sinus infections, pneumonia. They could also have unusual infections. They may have failure to thrive, all right? Or there could be that genetic factor, family history. Okay, regarding nursing care, we're going to, of course, ensure good infection prevention with these patients. So we're going to do this by practicing strict hand hygiene. Make sure that before you go in a room, you're washing your hands thoroughly, and when you exit a room, again, you are washing your hands before you leave. You want to use any other infection control precautions, so really keep an eye on anything that may be on the door before you go in so that you are using proper infection control precautions. You want to monitor for early signs of infection, so looking for things like fever, okay? That's one of the earliest signs you can see. They may have flu-like symptoms if they are really getting worn down. We want to teach home medication therapy administration and provide education and ongoing support. More than anything, really important that you are recognizing this and not blowing the patient off. A lot of people who have any type of immune issues or allergies, etc., people are just blowing them off. We cannot do that, especially here in the state of Missouri. Let's move on to HIV and AIDS. So, HIV is the virus, all right? So it's the human immunodeficiency virus. It's actually attacking our CD4 and T cells, and it's weakening the immune system, all right? If it's not treated, it can escalate to the actual disease of AIDS, all right, which is autoimmune deficiency syndrome. It's very susceptible to infections at that stage, all right? So goal is to prevent HIV and AIDS, and so a big piece of what we as nurses do are helping educate, so that's what we're going to focus on here. And we will also focus on how we treat if somebody does get AIDS. Our biggest thing and goal is to prevent HIV. If someone does have HIV, then our biggest goal is preventing it from escalating to AIDS. Okay, we are going to discuss the three main stages of HIV/AIDS. Stage 1, Stage 2 is considered HIV. Stage 3 is AIDS. Stage 1, we call that the acute or primary stage. You are going to see flu-like symptoms in your patients. This is the period from when they are infected with HIV to the development of HIV-specific antibodies. You're going to see their CD4 count drop dramatically. Normally that CD4 is way up. It's going to still be above 500. It's not going to drop below 500 yet. If it were, it would be a different stage. However, stage 1, CD4 count is still above 500. They may or may not have those flu-like symptoms. They may exhibit fatigue, though, or skin rash. Stage 2, so that CD4 count is going to continue to drop. And this will happen if they're not having the medications. So if they let that flu-like symptoms continue to go on for a while, their CD4 count continues to drop, and they are in stage 2. This is when it's between 200 and 499 on that CD4 count. Signs and symptoms are getting worse. They could then, at this point, be having pneumonia. They could be short of breath, have a cough, have chest pain. They're continuously fatigued. They could still have that skin rash, but it's getting worse. All right, then we have stage 3. When it hits stage 3, that CD4 count is dropping below 200, and it is considered AIDS. All right, so stage 1, stage 2, they have the virus, HIV. Okay, stage 3, it's progressed onto the actual disease then, which is AIDS. With the AIDS then, you need to know that, again, that CD4 count is below 200. For signs and symptoms, they could have what's called the wasting syndrome. So they've lost so much weight, they look anorexic, they're having so many GI issues, a lot of nausea, vomiting. They could have a type of cancer called Kaposi sarcoma. You can see that here on the far bottom right of your screen. They could have, you can see a good picture of the wasting syndrome right to the left of that as well. It just skin and bones, all right? And then they may also have HIV encephalopathy. So this is basically associated form of dementia for AIDS patients. So that virus, the HIV infection, has actually gone up and invaded their brain. Okay, so there's inflammation and damage to the brain tissue. It's leading to a whole range of neurocognitive impairments. We want to think about their mental health as they're going through this. There's a lot of stereotypes out there about HIV and AIDS. The biggest thing I need you to know also is treatment has come really, really far. And we'll discuss that more as we go on. All right, let's go through the CD4 count a little bit more within these stages. So over here to the far left, we have before HIV, what your blood is looking like with that CD4 count. That's what those blue circles represent. So that is a healthy picture, healthy person before infected with the HIV. Okay, so then we have stage 1, which is the second little picture over. That's the acute or primary HIV infection stage, usually 2 to 4 weeks. It could take longer than that. You can see already that CD4 count, those blue circles, are decreasing. All right, so at stage 1 right here, that is when, again, you are seeing that CD4 still above 500, but it's obviously decreasing dramatically. Okay, what you're also seeing is the virus, those little red dots are creeping in. Okay, and that's what's destroying the blue dots, the blue circles. All right. This stage, again, happens within the first 2 to 4 weeks, sometimes in months. We are, think about the signs and symptoms at this phase. Again, the flu-like symptoms, that virus is attacking those CD4s. We are seeing, again, that the CD4 is dropping and the viral load is going up. So those blue dots are decreasing, the red dots are increasing. We are giving them what's called ART therapy or antiretroviral therapy during this stage. That's going to help get rid of that virus and bring it down and help prevent the patient from transmitting the HIV to another individual. It can still happen, but it really decreases their chance of spreading it. Then we have the second stage. You can see those next 4 pictures. it could be 10 plus years in stage 2. They could be asymptomatic. We could really be keeping their viral load down and their CD4 count up. Worst case scenario, you'll see what's happening in this picture, where on the first picture there of those 4, that CD4 count is going down. The second one, it's going down more in the third, and the last one there is it barely has it. And you can see the red dots are increasing. When that's happening, that means that antiretroviral therapy is either not working or the patient has not been diagnosed and they're leading straight to AIDS, okay? So at this stage, again, they could be asymptomatic for years. They could call it the clinical latency phase. Again, HIV continues to multiply because there is no cure for it, but we're hoping to slow that process down. And we slow that down with that antiretroviral therapy. Then we have the third phase, that's the AIDS. That's the far right picture, that's stage 3. Your CD4 count is below 200, and you can see the virus is really taking over the body. That's when we're getting that Kaposi sarcoma. They could have really bad pneumonia. They could have herpes simplex of their mouth or genitals. They could have tuberculosis. Lots of other diseases could be going on as well. That their immune system is shot at this point. And by the time it's progressed to this and they have AIDS, again, there is no cure for AIDS. What they are trying to do still is try to bring that viral load down to give that patient more time. Okay, here are some of the ways that HIV can be transmitted into the body. One of the biggest things you'll see is through seminal fluid, could be through vaginal secretions, could be through blood and blood products. However, we've gotten way better with the blood and blood products, and that rarely happens anymore. It could be mother to child through the amniotic fluid, breast milk. So all pregnant women should actually be tested. Other things to think about: what should nurses do to protect themselves? So remember, you need to know how it's transmitted. It's not transmitted through casual contact. So if you have a patient who has HIV or AIDS, you need to be careful when it comes to things like blood and blood products, starting IVs, dealing with wounds, things like that. And then you think about the other things as well, but you are not going to get AIDS or HIV virus through casual contact. If you, for some reason, have a stick of, if you stick yourself during, starting an IV, etc., there are protocols and procedures at each hospital. You want to make sure you go off of those. And usually that is, and if you're in nursing school, you'd want to make sure that, your professor knows as well, so they can make sure the proper channels are aware and you're following the procedures there as well. Post-exposure prophylaxis. So at times they may have to do the ART medications within 72 hours of exposure. Sometimes 2 to 3 drugs are prescribed for 28 days. And that's if you've been exposed to HIV. Okay, a little bit more about the risk factors. We already talked about some of these in the previous slide, but just so we're aware: unprotected sex, multiple sex partners, healthcare workers, perinatal exposure, blood transfusions, although very rare now, IV drug use, and older individuals. And it's with the older individuals, why is that happening? Of course, because they more than likely have a decreased immune system. In terms of health promotion and disease prevention, education is a big piece of what we nurses do. So we want to think about safe sexual practice, abstinence, and no needle sharing. We want to think about HIV testing early, especially for anybody who feels they have been infected or if they've had unsafe sexual practices. If they are pregnant, they will have an HIV test. We want to ensure patients who are diagnosed with HIV are connected to a primary care provider. We want to make sure they are getting the right ART therapy to reduce the risk of transmission, and we want to make sure we're getting that viral load down. We want to get them in contact with peer-led programs to reach high-risk groups. So people that may be sex workers, and also underserved communities. We want to have school-based HIV education, so especially there in not just high school, but at the middle school age, especially now too. And we want to think about the LGBTQ plus community. And medication-based prevention. So we can educate on the pre-exposure prophylaxis and post-exposure prophylactic medications, and because this is very effective in preventing HIV transmission. Okay, so how do we get someone tested? Well, first and foremost, we want to make sure that people are aware of the various locations they can go. So if we're in the hospital, all this information I put on here is what you're going to need to know. We also want to know, though, that places like the local health department could have low-cost HIV testing. Places like Planned Parenthood could. Urgent care clinics do. Some of the community health clinics do. Your doctor's office has them. Pharmacies have them. You can also order them online. So there's a lot of options out there. The CDC also recommends routine HIV testing for everyone aged 13 to 64, at least once, with more frequent testing for those at higher risk. And we've talked about those who are at higher risk, unsafe sexual practices, sex workers, healthcare workers if needed, etc. So for testing, though, if someone comes in and we are needing to test them, we can start with this ELISA test first, all right? We do that one. If it's showing up positive, we follow it by usually that Western blot test to confirm the HIV. Then after that, if needed, if those are positive, we would do the HIV viral load test to see what their viral load is at that point. Then, of course, we're going to start checking other things like their CBC. We want to look for anemia. So we're going to be checking their RBCs, their red blood count, or their H&H, their hemoglobin and hematocrit. We'll also look for leukopenia, which is low blood cells, and thrombocytopenia, which is low platelets. We also, depending on what the assessment shows, if they're having issues, other issues, they may have to order a liver profile. They may need to test their stool for parasites, so do something called the guaiac. They may need a brain scan, a lung scan. All of this all depends on what signs, symptoms the patient is showing. Okay, in terms of treatment, so we want to think about that antiretroviral therapy, that ART or ART therapy. So that goal is to suppress the HIV replication process. All right, so we want to, again, get that viral load down. Think back to that picture before. That's a really great example of what we're trying to have happen with the viral load and the CD4 count. We want to reduce HIV-associated morbidity and prolonged duration and quality of life. All right, so get that viral load down, get that CD4 count up. We want to restore and preserve immunologic function. All right, again, that has to do more with that CD4 count. We want to suppress plasma HIV viral load. We want to prevent HIV transmission. All right, next thing up, our goal is to begin other treatments. We want to improve nutritional status. So we're going to do things like monitoring their weight, their INOs, what is their serum albumin looking like. We may want to think about dietary consults as needed. And we want to instruct ways to supplement nutrition. We want to decrease their sense of isolation. Again, there's a big stereotype around HIV and AIDS. So assess their pattern of social interaction. We want to observe for behaviors indicative of social isolation. And we're going to assist with identifying resources and keeping that CD4 count elevated. We want to improve nutritional status. Again, I think I've got that on there already. I doubled up on that one. All right. Other things, absence of complications. We want to educate them, so increase their knowledge regarding the disease prevention and self-care. And you can see that nice picture right there about the ART therapy and how far it has come from the 1990s to today. Right, more on nursing care. We want to assess the risk factors. Again, this goes back to your health assessment class, really thinking about a good health history and a good assessment of your patient. Ask lots and lots of questions. All right, so we want to know their sexual practices, if they have any IV drug use. We would like to monitor their INOs. So we need to know intake and urinary output. That's usually done often throughout your shift. Make sure that you are aware of that. It's an ongoing thing. You want to make sure you have that INO down. You want to obtain daily weights at the same time each day. We're looking for weight loss. Usually the daily weights are happening around 6 in the morning. It's a great time to do it. Go around and get everyone's done at the same time. Or about the same time. We'll monitor those labs, as we had said, as necessary, especially those electrolytes. We want to assess their skin integrity because remember, they have skin rashes and so forth. Assess their pain status. We want to monitor their vital signs, especially that temperature, because possible opportunistic infections. We want to assess their lung sounds, respiratory status. They may have diminished lung sounds. We want to assess their neuro status for confusion, right? Think about that HIV encephalopathy, that dementia. Visual changes is another one. We want to encourage activity with rest also. They shouldn't just be laying around all the time, but realize they will be quite fatigued at times. Administer oxygen as needed, provide pain medicine as needed, provide skincare as needed. In terms of medications, highly active antiretroviral therapy involves using a combination of medications. Biggest thing I want you to remember is, again, those medications have gone from a handful down to just a few, just here in the last few decades. So may include all of these below. Think about those. You don't have to have these memorized for this particular activity. For interprofessional care, here's what each of these services can do for our patients who may have HIV or AIDS. So infectious disease services, they can provide specialized care to manage and treat that HIV infection, okay, including prescribing that ART therapy. Respiratory services can assist in managing any respiratory complications common with these particular patients, especially such as pneumonia or TB. Nutritional services can help address the malnutrition and weight loss. Rehab services can help offer physical therapy to address any of that muscle weakness, neuropathy, mobility issues. Home health services, if they go home, they could deliver in-home medical care such as wound care, medication admin, monitoring of symptoms. All right. Long-term care services offer supportive living environment for patients with, again, advanced HIV or AIDS. And then our hospice services, providing comfort-focused care for terminal stage AIDS patients. Here are the different things we talked about today. We talked about the PIDD, the primary immunodeficiency diseases. We talked about infectious disease management with HIV and AIDS. We talked about the nutritional support with HIV and AIDS and the interdisciplinary services with HIV and AIDS.